Okay, so let's get started. So I want to welcome all of you to this, on behalf of ADVAC, to this ADVAC webinar on communications related to the deployment of COVID vaccines. I think it's obviously a very timely webinar. It stimulated a lot of interest as we got many registrations. I don't know if all will connect due to the situation, but hopefully we'll have quite an interesting discussion. I want to remind you the rules of the game, which is that unfortunately, due to the large number of participants, only the chair, the presenter, and the panelist will be able to speak, and will go on video mode. However, all of you will be able to ask questions, and these questions will be answered as much as possible. We apologize if due to time we cannot have all the questions answered. When you ask the questions, please do use the question and answers box. Do not use the chat box. Whatever you put in the chat box will not be asked as questions. Otherwise, I will monitor the questions and ask the questions for you when prompted by Noni. So I want to briefly turn to Noni, introduce Noni, and she may not need any introduction to you. I reckon most of you know her well. She's quite familiar to ADVACers, having contributed largely to the program and previous webinars. Noni is a professor of pediatrics from Dalhousie University, of which she was the dean previously. Noni has two passions, vaccines and micro-research. And for vaccines, she's contributed tremendously in the area of safety, hesitancy, communication, acceptance, and so forth. And she has served on the Global Advisory Committee on Vaccine Safety of WHO, and currently on the Strategic Advisory Group of Experts. And her second passion is about micro-research to find solutions, local solutions to local public health problems. Noni is well known also in low and middle income countries, and has donated a lot of her time, not only to WHO, but to various programs. And she's the passionate advocate of the cause of children's health. And she's actually been recognized internationally, and more recently in Canada, where she got the highest distinction in the country, since she was named to the Order of Canada, which is really the highest distinction in our country. And Noni is passionate about communication, so I think that nobody else than Noni should be the chair of this meeting. On to you, Noni.
Thanks very much, Phil. I much appreciate the comments and the a little more flowery introduction than I had expected. I'm super pleased today to introduce to you Susan Mckay. I think many of you already know Susan, and we need to understand that Susan really has gotten out of her sickbed to be able to do this. She came in on very short notice because Lisa Menning, who was going to do this, is traveling back to see a member of her family who is ill. And Susan has a very interesting and eclectic background. Susan heads up Gavi's work on demand generation, communities and gender at the Gavi Secretariat in Geneva. She has a master's in applied anthropology and participatory development from Canberra. And before Gavi, Susan has, I think Susan, I first met you probably in Vietnam, but I'm not sure, many years ago. But she's worked for a number of UN agencies. She's headed up the communications for polio eradication. She also worked for UNICEF and for WHO. And most interesting, Susan also worked for the BBC as a studio manager and a senior producer for BBC World Services. So she has one of those really eclectic, broad communications background with a behavioral sciences underpinning to it. So Susan, we're looking forward to your presentation on communication about the deployment of COVID-19 vaccines. Take it away, please, Susan.
Thank you very much, Noni. And actually, I'm slightly embarrassed to admit that the very first time I met you was 2 decades ago. I was where I was a very young communication officer, a technical officer for WHO, and I was giving my very first workshop session on vaccine safety communications, and I was doing it with a master. So it's slightly, I'm absolutely honored to be joining you again today. And I have to say that most of what I've learned about vaccine safety communications has come from learning. So I hope we can share some of that today. Can you see my screen?
Yes.
It's best if you move to full screen, if you move to full screen mode.
Yeah, it's just gone underneath. Hang on, I just need to move. Okay, thank you very much. This is a really important issue to engage you on. I think this really sets the scene really nicely. This quote from it's the beginning of the Sabin Aspin report on vaccine science and policy. COVID-19 arrived at a time when hesitancy about long-established vaccines was a real and present danger. Although vaccination remains a well-accepted social norm worldwide, the combination of factors, including misinformation, spread on social media, decreased trust in institutions, including government, science and industry, and weaknesses within health systems has emerged to diminish confidence. And I think we really do describe it as the perfect storm. I think communication is really one of the most critical elements in preparing for this very rapid deployment of vaccines that are still to be developed. And I think this is, anyone that's been working in immunization, this is a completely unprecedented situation. And for us, working on the communication side, but actually it goes further than communication. And what we need is a really comprehensive, behaviorally driven strategy for uptake and demand. And this is very much moving from communication into science and human behavioral aspects. I think this kind of image is obviously, it's pretty emotional for all of us this week. I think we've seen scenes like this around the world, that we've been hit by an unprecedented infodemic of misinformation, polarization, and really it's just been a tsunami that has swept upon us. And I love this article that was published in Nature by Neil Johnson and company. If what you see here is a visualization of Facebook pages which are either pro-vaccine, anti-vaccine, which is the red, or green, which is neutral. And what you see here is that the blue, the spots here, they're almost like in a bubble of pro-vaccine people talking to pro-vaccine people and really not engaging with the audiences of the neutral audiences, the ones who could be influenced and brought across to our argument. And what you see is that these red dots are highly influential in these networks. So I think this is quite, actually seeing this, that it doesn't matter how much work we do, we're just speaking to ourselves largely. This report, I think, is really important, published by the Center for Countering Digital Hate. And they actually did a systematic look at what was happening in terms of vaccine-related conversation in social media. And there's really, we're all calling for social responsibility within the tech companies. But I think the sobering point here is that, of course, this is business ultimately. And I think in this report, they identified that up to 95% of content that was flagged as being problematic had not been removed. Now, I have to say, I'm working in an organization that is engaging with social media platforms. We are all trying to make this a more responsible place. And we're working with a lot of people who want the same thing. But it's actually a very complicated piece of work. But I think it does call on this group that I'm speaking to today to be very noisy in this space in terms of influencing and leveraging the conversation. And it's ultimately a policy question. I think this has come again on a backdrop of low trust, and I'm using a topical picture from this week, but we could be using a picture from all of your countries, and certainly I'm sitting here talking to you from Switzerland, and we've had protests and masks, protests against mask wearing, and it's very much it's a very unsettling time for us all in terms of the emotions that are running, and also the activation that we simply have not seen on this scale before. What we're also seeing communicated is data, and there are surveys coming out frequently. Now, this is an Ipsos survey that you may already have seen, but it's interesting because it covers a lot of countries globally, and this study is saying that 3 in 4 adults globally would say they would get a vaccine. Most don't expect it to be available to before the end of the year or into next year. And of course, they're saying that side effects would be the concern that they would worry about most. It's interesting there, you can see on the slide the countries where the support is highest and lowest. But this is a poll, and this does not necessarily translate into the behavior that we might actually see. And of course, this is a conversation that is running, and we're seeing polls every week with different results. And as a communication person, I would also say these are so important in the news. The question is, how are they influencing how people, we're seeing data, but it's influencing also the way people are relating to the argument. And if we as people who are charged with trying to generate confidence, uptake, demand for this vaccine, we need to be very cognizant of this ongoing conversation and dialogue and be somehow able to influence it in a strong way. This poll from the Pew Research Center, it's the data from September, also showing it's the trends that we're looking at, which are also concerning. And you see here, and this is all relating to the politicization, the idea that people feel that the vaccine, certainly the conversation in the US about getting the vaccine rushed out before the election, and hopefully now that we are in the week of the election, hopefully that kind of driver, that we can see a resetting of that discussion, which is really important. And we've seen the influence of politics on vaccine uptake, for example, in Indonesia, with the presidential campaign that really impacted on a measles rubella campaign that was happening in the country, and caused quite a drop in confidence because it was the conversation was polarized and harnessed for political means. Of course, we're in a really complicated situation. Certainly, I'm working at the Gavi Secretariat, and very much we're involved in the conversation about equity. And you will be aware we're working with WHO and other partners in terms of the launch of the COVAX facility and working for fair distribution, equity in the distribution of any vaccines that come forward. And equity is going to be a really important discussion because the whole idea of short supply, we've been very challenged with this in the introduction of HPV, for example, that in fact, it's not been about creating demand for a vaccine, it's been actually controlling the conversation around the lack of availability and how do we ensure the fact that there may be very high amounts of demand that we can't meet, or should there be a problem, there could be a drop in confidence. And that brings me to the point that we are in a very new territory in terms of vaccine safety communications. We're not dealing with tried and tested vaccines. We're dealing with vaccines that are going to be introduced at speed to populations and to high-risk populations. So this is going to be a very, very challenging introduction. And also just the sheer number of vaccines in the portfolio. So going back to the data that we've been discussing in before we started the pandemic, I pulled out a slide from the Wellcome Trust Monitor, and this is work the Vaccine Confidence Project has been involved in. But certainly one of their really important points is that for those who have trust in frontline health providers are most likely to believe that vaccines are safe. And I think that really, for me, that all of our vaccine safety work, that getting the health cadres on board with us is absolutely vital, and even more so in this introduction, where they will even be the first line to receive it. But what we see here is that at very differing levels across it. Certainly Eastern and Western Europe, certainly in Eastern Europe, there have been trust issues around healthcare in terms of quality issues around healthcare. In Western Europe, even though trust in nurses and doctors is very high, at the same time, there's certainly the trust issues that we've seen from the era of Wakefield. And certainly I was working with Dr. Duclos in those days in the early aftermath of that, that still influences the conversation around vaccines in Western Europe. And that shows you the longevity of these issues. So what are we going to do about it? I think this is, where is our action going to be? We very much see this not as just a communication campaign. We see this as a very integrated, data-driven, behaviorally informed approach. The first thing we need to do is really understand the social and behavioral drivers of vaccine uptake and demand. There's another new area of work that has emerged very rapidly in response to the infodemic, which is that we need to undertake systematic social listening and engagement. And I'm delighted, actually, if there's any sort of bright thing that's emerged from all of this, is the fact that we've managed to fast track, UNICEF is working with other partners to fast track the systematic use of social listening in countries that may not have been trying these approaches, and building the Vaccine Demand Observatory. And this is a really bold and exciting piece of work where we're systematically using technology platforms to systematically analyze social listening. However, it goes beyond digital, because we understand, particularly from polio and also from Ebola introduction, the importance of, in countries that are media not so open or not so tech advanced, that we certainly need to find a way to get analog listening, rumor tracking, and feed that also into the digital system. The third component here, frontline workers, as I said, early adopters, a green component around the behaviorally informed interventions, risk communication, crisis communications, but very much driven by data real time as possible, and that investing in community engagement. So that's very much where we see the kind of integrated approach. And just diving into these a little bit more, I do want to draw attention to the BEST work. Lisa would have been talking about this today. She's leading it from WHO's side. It's work led by Julie Leask and Noel Brewer, and a team of experts from around the world who've really worked very hard to come up with framing in terms of understanding how do we measure these aspects of vaccine uptake and demand. And they have the BES model that you may already have seen, looking at how to measure the way that people think and feel, the social processes that lead into motivation, but also very important, the practical dimensions, the ease, the affordability, the service quality, respect, dignity, these aspects, and how that results in vaccination. And I think this is really critical if we're to move beyond the poll that is simply a snapshot in time, but this is a much more scientific approach to this. This team have rapidly developed a questionnaire tool for COVID-19 vaccine introduction, and we hope to see this being validated and hope to take it to scale. It is that social listening I was talking about, this supportive information environment, and addressing misinformation proactively through this social listening that leads to understanding, and that informs the interventions. And certainly lots of things happening on this front, but it's extremely important that we get compelling content out there that is even more compelling than the mis and disinformation that is being spread. Here, this points to the health workers. We've got teams who are looking at what tools, approaches. I know that Naveen is on the call, certainly the working with IPA and others to make sure that frontline health workers, influencers have the right tools in their hands to raise the knowledge. But we're also going to have to address the worries, the risks, the concerns of frontline health providers, and somehow using that understanding and that learning to turn them into our most powerful frontline advocates, and to be as persuasive with the target populations as possible. this listening, but I'm putting this here. I've been working on parents and caregivers and people around childhood vaccination, and we're very quickly having to pivot to high-risk populations. And these are populations we do not have mechanisms easily to reach. And so it's also about making sure that our tools, which we're looking at parents thinking about their child's vaccination, how do we quickly pivot and look at the adult questions around this and perceptions about vaccines for themselves. And really, apart from flu vaccination, which is not in the countries that I'm most concerned about at scale, but really also, I mean, the only experience that I can think of that's relevant is TT, for example, maternal and neonatal tetanus. And we did find it was very different about what mums would say about what they would do for their child versus actually whether they would take the vaccine for themselves. This piece here, and I think really we are needing to reach out to NGOs, CSOs, organizations that understand high-risk populations, the elderly, and rapidly try and build a delivery system and a communication system that is going to reach and build trust with this very new group for us. And I'm just going to close here and just pointing to the importance of vaccine safety communications. There are a lot of tools, these networked and resourced, the vaccine safety net. Actually, Philippe, I think, and I worked on the very first TOR for this 20 odd years ago, showing my age there. But I'm absolutely delighted that it has grown into this really powerful network. And if I have to say, Philippe, I think we kind of looked ahead to what was going to be needed for today. Anyway, I'll leave it there, and I just want to open I hope that stimulates a really powerful discussion. Thank you.
Thank you so much, Susan. Pretty amazing for having done this out of your sick bed. I'm terribly impressed, and lovely to have you here today. We have a number of panelists that are going to respond to some of your comments, as well as some other questions that we had put forward. And then I hope we'll do some Q&As from the other people who've tuned in. So for each of the panelists, what I'd like you to do is introduce yourself. I'll call your name and then you can introduce yourself. We're very sorry that one of the panelists was not able to join us today because of a COVID crisis, which is pretty common in most countries. And when they call, and you have to do something. So Deepa Gamage from Sri Lanka is not able to be with us. So if each of you can introduce yourself very, very briefly. Jacob Kramer.
Yes, thank you. My name is Jacob Kramer. I have a clinical background, spent 14 years in clinical medicine, tropical medicine, infectious diseases, travel medicine. Before I joined industry, I worked 5 years in clinical development, Takeda, involved in dengue programs, NOR programs, polio, and then joined last year CEPI, the Coalition for Epidemic Preparedness, as head of clinical development. I'm based in London, but I've been stuck at home. Home is northern Germany for several months now due to COVID. Thank you. Pleasure to be here. Thank you for inviting me.
And Ron Dagan? Oh, you're muted, Ron. You have to unmute.
I think it's the first time in your life that you got me muted. I'm from southern Israel, from the Ben Gurion University in Beersheba. I'm a pediatrician. I work on vaccines in the last 30 or 40 years, and I'm involved in various aspects of vaccine, from impact to development of vaccines.
And Margie Danchin, who's way up in the middle of the night in Australia, but take it away, Margie.
Thanks, Noni, and thanks, Philippe, for the invitation to speak today. I'm a paediatrician in Melbourne, in Australia, and also I lead the vaccine uptake group at the Murdoch Children's Research Institute and the University of Melbourne. And really my whole program of research is around looking at improving vaccine uptake, particularly amongst high-risk groups, but also work very closely with Julie Leask and others, and Lisa Manning and around the BESD work. So yeah, nice to see you all.
I'm going to do this slightly out because the way my screen is. So Rodolfo, do you want to go next?
Hi, good morning, good evening, and good afternoon everywhere you are. Thank you for the invitation to participate. I'm an infectious disease subspecialist. I'm a pediatrician as well. and I work in a public hospital in Santiago and the University of Chile. And I'm also member of the technical committee for vaccine pharmacovigilance in the Public Health Institute in my country. And nowadays I'm one of the investigators in one of those COVID vaccines that are in phase 3 clinical study.
And then Keep, do you want to come next? You got to unmute.
I just had to find the button. Good morning, everyone. It's morning for me. I'm Kip Talbot. I am from Vanderbilt University in the US. I currently serve on the US Advisory Committee for Immunization Practices, and I'm a little bit different than most. I'm interested in adult and geriatric vaccines. This has fallen into my wheelhouse, as you can imagine, COVID has, and so I spent a lot of time thinking about that.
And then Naveen?
Yeah, so I am Naveen Thakkar. I am currently Executive Director of International Pediatric Association. I served on Gavi board as CSO representative. So nice to see you, Sujan, here, and wish you a very speedy recovery. Currently, as she mentioned, we are about to launch a project called IPA Vaccine Trust Project. And we have a course starting from behavioral science, infodemiology, social media, something which is not taught in medical school. And Noni, Margi, are one of our faculty, and we are translating that into the say 6 languages. And our focus will be on pediatrician and other healthcare professional. And with Sabine Institute, within 2 weeks, we are launching that in 7 Gavi transition countries. And we look forward to play our part. I picked up vaccine hesitancy sitting in Gavi board 3 years back when, we started hearing from chair and everyone, vaccine hesitancy. And then I started working on that. So I think we are very well prepared to play our part and work through the IPA and also for the healthcare professional. Thank you.
Sonali.
Thank you, Noni. I'm a clinical associate professor with the Department of Global Health at University of Washington in Seattle, and medical director with Global Healthcare Consulting. My background has been over 2 decades of leading phase 1 to phase 4 clinical research, safety and epidemiology studies, and implementation research for vaccines in adult, maternal, and pediatric populations. Worked extensively on vaccines for infectious diseases, including COVID-19, HIV/AIDS, MERS, Lassa, Nipah, and so on. Maternal immunization, safety, regulatory, and ethical strategies for clinical research for vaccines, including for epidemics in pregnant women, on pandemic preparedness and response, introduction of new vaccines, increasing immunization coverage and acceptance, and strengthening of immunization programs. I serve on the WHO SAGE working group on COVID-19 vaccines, WHO GACS working group on COVID-19 vaccine safety preparedness, and on the WHO ACT Accelerator Ethics and Governance working group. Thank you.
Thanks, Sonali. And then Hannah.
Yeah, hi to everyone. I'm Hanna Nohinek from Helsinki, Finland, and I'm an MD PhD vaccinologist. I used to do clinical trials until 2010, mostly in the Philippines, and thereafter I joined the public health program. Narcolepsy post-pandemics was the first thing I had to deal with as a vaccine safety officer, and I've been on that ride since, working on vaccine safety. I'm presently secretary of the Finnish NITAG, and I'm also chairing the WHO SAGE working group on COVID vaccines. Over.
So a couple of points that I'd like to have comments back from all of you, including Susan. One of the things that's so different for COVID is we're going to have a whole bunch of different vaccines that are not the same. And we've never done this, even in a single country before. And we're going to do this all over the world. So how do we try to get communications to sound the same? Because when somebody says it's black over here and they say, well, it's not quite black, it's more dark gray. And then somebody says it's blue over here and somebody else says it's, well, I think it's opalescent gray. It sounds very different. So Susan, your comment on that, and then I'm very interested in what Jacob and Margie would say about that.
It's almost, I am speechless about this. It's very hard to get our head around. And I can't help feeling with all of our backgrounds that, you know, as a communication person, we are literally playing with fire here. That's the honest answer to that.
Margie?
Thanks, Noni. I think for me, what is really missing here is a lack of investment in social and behavioural insight data collection. And I think now the time has come, honestly, globally, for governments and funding bodies to stand up and realise that this is the data we need. As you've just described, Noni, this is the challenge in all these different environments and countries. We need social and behavioural insight data. And for some reason, there's a complete block in governments collecting these data and regularly tracking. You know, there's no systemic collection of survey data in Australia around COVID vaccine acceptance and some of these confidence issues. We have huge problems here around rising anti-vaccination activity and misinformation, as is happening globally. And we're really struggling to get funding to actually understand the sort of the views of the underserved and the marginalised populations. So here, where I live in Melbourne, we've had the worst numbers of coronavirus cases in Australia. It's almost like we've been a separate country. And the worst outbreak, I beg your pardon, occurred in July in some housing commission towers. There were 9 towers and 3,000 residents were completely locked down and unable to leave. And there were huge numbers of cases and casualties. And there was no engagement with community and religious leaders. There was no tailored and targeted communication with those people. There were no translated resources. It was just really, you know, horrifying to watch, actually. And I suspect this is what's playing out all over the world, is we're not actually standing up now and actually trying to collect these data to drive the communications that we all know are needed, as Susan so beautifully presented, to tackle the misinformation and to be able to give the sort of tailored communication strategies. I sit on the Australian government, the ATAGI, the Australian Technical Advisory Group on Immunisation for COVID vaccines. So I'm working with the government around the communication strategies. And there's such a vanilla approach to kind of broad-based communication campaigns, but they're not actually talking about getting the nitty-gritty data, Noni, that you're talking about, and thinking about different communication channels, communicating with communities on the ground, using the radio or other strategies for communication. It's this sort of bland, broad communication approach, which I'm sure you're seeing in your country. So honestly, when you said, what are the tripwires? I think now is the time really that we need to actually put social and behavioural science data collection front and centre.
And Jacob, one of the big issues for many of us are all of these vaccines that are coming through CEPI and hopefully will be in the COVAX manufacturing piece. They're not all the same. They're very different, and they're likely going to have different side effects. They're likely going to have different ages at which they're going to work the best. How are we going to keep them separated? You know, it's pretty easy when we say PCV10 and, you know, PCV, PPV23 and so on, PCV13. This is very going to be hard with the COVID vaccines to differentiate. Have you guys at CEPI been thinking about how we can, because that's a big communication piece.
Yes, so communication is key. It's a no-brainer really, but beyond this no-brainer sentence, it's getting really difficult. I think Susan outlined it very nicely, you know, the hesitancy in the discussion, and you know, I'm from Germany, and we struggle with eliminating measles because of the large proportions of vaccine hesitancy here in even, you know, my home country. But we have the general hesitancy and concerns related to vaccine as a concept per se. And then certainly we have COVID-19 vaccine specific concerns. And the general concerns certainly feed and influence in the perception of vaccine as a tool to fight this pandemic. But if something goes wrong with COVID vaccines in general, or with single COVID vaccines, this will have a huge impact on vaccine hesitancy in general. So I think we do have a huge risk if things go wrong. And honestly, if I look at the COVAX or CEPI portfolio, a large proportion of vaccine candidates that we are working on are based on completely new platform technologies. There is no licensed vaccine out there for RNA vaccines or for DNA vaccines. And even the vector-based vaccines, there isn't too many vaccines licensed so far. So we do have a risk, and I guess I'm the pre-licensure guy here on the call, so really representing clinical development. So we are, I mean, obviously communication is based on what happens after vaccines are deployed and used and signals that are being detected then. But obviously communication also relies on the data that are generated before licensure, so during clinical development. And obviously there's these two aspects that we always look for, and that is vaccine efficacy and vaccine safety. But I would like to add, trust that has to be generated even pre-licensure on those different platforms. I have to say it is unlikely that all these different vaccines will be comparable in terms of point estimates for vaccine efficacy, dosing regimens, storage, suitability in different subpopulations and so on. It's very unlikely. There will be, some maybe have single dose and suitable and immunocompromised, but have a lower point estimate for vaccine efficacy. I think we are still in a safe environment now, as long as we do not have data out there from first interim analyses, but they are now coming soon. And that will trigger the discussion, because these interim analyses will have more variability even than final target point estimate or point estimates based on the full analyses. And I'm holding my breath. Well, I guess I need to breathe oxygen, but at the same time, I want to hold my breath in anticipation of these data, because I'm a little bit afraid of the discussion that's coming our end, honestly.
Yeah, Ron, you have a comment to make on this too.
Yeah, I think, your questions comes a little bit with, I'm from the Middle East, so we state things a little bit more sharp. It's very polite to say. First, a big part of what Susan was talking is the vaccine hesitant people. But the difference between what we have now and vaccine hesitancy, that in vaccine hesitancy, and you gave the example of measles, is that you have the knowledge, people don't believe you. Here, we don't have the knowledge. So the problem is the speed of development of vaccines in the presence of what we don't know. So if forget about me being a vaccine person. I am a father and a grandfather, and myself an elderly. And so all of us are in the question of vaccine, and I don't know anything. And I didn't take yet the pneumococcal vaccine to myself. I'm 74 because I don't know what's better, and I think that is a problem. So the main issue is what do I get? What do I know about efficacy? What do I know about safety? And what do I know about correlate of protection? If I don't know any one of these, how do I communicate to take a vaccine still without knowledge, because we don't have time to get the knowledge? So I think the whole idea of communication here is getting people to accept actions with high degree of uncertainty, but a balance that can be positive with certain risk. That will be, for me, a line to be transparent and at the same time clear and active.
So Ron, if I'm going to add to your point, and then Keith, I really want to hear about you, because we've got populations we've never had to reach in the volumes we're talking about. Going back to what you've just said, Ron, we've got issues that are around what we know and what we don't know. And if we're going to be trusted, we need to be sure that people understand that we're not lying to them, that we're telling them, this is what we know, this is what we don't know, this is how we're going to move forward in this unknown sea that we have to cross because we don't have a choice. I mean, leaving the world as it is right now when people are dying every day isn't an acceptable option. We've got to look at what we can do and what is the best way forward. I want to digress for 90 seconds to say the question in the survey, Susan, a lot of us have had some trouble with them, because if I said to you, I want to sell you a car, and I'll tell you it's a safe car and it has good gas mileage, would you buy it? And the answer is no, because there's a lot of other information, just as Ron has said, that you want to know before you're going to buy. And that's our problem here, is we don't know a lot of this stuff. And I'm not sure, and Susan, you raised it yourself, I don't know how helpful some of these surveys about will you take the vaccine are, because I think it's making people say, whoa, wait a second, I'm not ready to make that decision yet. And we haven't asked it in perhaps the best way. So can I go to Keep and then to Rodolfo? Keep.
Yeah, I have so many thoughts and I'm trying to tame them and wrangle them in. So we were in a very interesting spot at the Advisory Committee for Immunization Practices. It is a public meeting because it's a federal meeting, and many anti-vaxxers show up every time in large numbers and have time for public comment. And one of the most common comments that we get is, you approve vaccines without data. They feel like if it's not a placebo control trial for every vaccine, it doesn't count. There are also a lot of other complaints, and we are now sitting in the room virtually, but we are talking about approving a COVID vaccine, and none of us are comfortable recommending who should get the vaccine because we have no data. And once we do, we feed into that monologue of the anti-vax group in the US that we recommend vaccines with no data. And this time they might actually be right. And then the flip side of that is there's a large proportion of the population that feels like we're not recommending it, which means we want people to die to make our president look bad. So we are in this very interesting position of, how do you talk about a vaccine that you know nothing about? How do you start making recommendations so that when you do find out it works and it's safe, that you can quickly get it out and have infrastructure in place to save those lives that we really do want to save despite what is said. And so it's a very interesting situation to be in. I think this is completely complicated in our country by the fact that the scientists are coming out saying it's black, and our current government structure is coming out saying it's red. And we had an amazing public health official come out and talk about what this would mean for the US, and she's never been allowed to talk to the press ever again, because they don't want that level of information going out. And so there is a lot of mistrust because of that. Some believe that the CDC is making stuff up. And then the other aspect is we don't know what's coming out of the CDC, if it's been checked by the White House or not. And so we're having a lot of mistrust because of that.
Rodolfo.
I do agree with all of you. I guess that there is too soon to communicate safety or efficacious data, because we don't know it. We are starting the phase 3 clinical trials, so it's too soon for it. But I think that we need to start to communicate at least simple messages regarding that the vaccine is going to be just another tool in the box against the COVID. We need to start with the simple thing, with the base. So if we are going to introduce our vaccines, we don't know which one, but we still need to keep the proper wearing masks or physical distancing or hand washing strategies. And we need to keep, at least start with that part of the communication. And we are going to deploy a vaccine. We don't know why, when, or how, but as safe as long as we know, and it could be efficacious, and our serious adverse reporting system is going to be enhanced and prepared for a proper timing response in a way to avoid the mistrust for the population, because the journalist is going to be, it's like they are monitoring the phase 3 studies. So if they heard or they knew something regarding something wrong happened with a guy who was vaccinated, he's going to extrapolate that it was a direct effect of the vaccine. So the people is going to be, the spread of the fear is going to be really, really fast. So at least in this gap between now and the deployment of the COVID-19 vaccines, we need to train our healthcare workers. And of course, we need to train the communicators, the journalists, and this is a possibility. We have time, because of course, I do agree that it has this high risk for a lot of misinformation. We are not so sure if this is going to be so good in a short period of time, but we still have a little time to train or to be prepared, at least in these base things.
Sonali.
Thank you. So to follow up, on what's been said, we know that, if not addressed, the vaccine hesitancy will fester and grow and adversely impact vaccine acceptance. So we thought that short, clear, evidence-based answers to COVID-19 vaccine safety questions are needed to inform and increase scientific literacy among stakeholders. And the Consider group was set up, which is co-led by Nani and myself. And the working group aims to facilitate scientific discussion between stakeholders, including frontline health workers with potential vaccine recipients, and increase the comprehension and transparency of information to facilitate COVID-19 vaccine acceptance and uptake. And we know that our frontline healthcare workers will be on the front line of the safety communication. So helping them, giving them responses about vaccine safety can possibly help improve their effectiveness and confidence as communicators. What we're trying to do is make sure that the answers that we're providing are understandable, accessible, reference publicly available studies and data, and potentially increase scientific discussion and transparency of information among key stakeholders. We're trying to use visual aids, including graphics and pictures and examples to explain the information. And we're hoping that the gateway belief theory that by communicating scientific consensus among medical scientists, this will who are serve on the working group about COVID-19 vaccine safety will reduce the the stakeholder concerns, and this is a living document which is posted on the CanVax website, which is a WHO vaccine safety net accredited site. And as more questions become available, the answers will be updated and new answers posted. So, we're trying to communicate proactively, effectively, and in a consistent fashion, because we know that that is going to be key to ensuring the uptake of the vaccines. And perhaps this will help to increase the uptake of other vaccines.
So Sonali, maybe in the Q&A place, you can put up the URL for where the site will be so that people can go to it if they're interested, and you can ask your questions there if you think it's going to be an important question for frontline healthcare workers. Hannah, do you want to make some comments, particularly coming from chairing the working group for SAGE on COVID-19 vaccines? I mean, this is a huge task, very complex, but the communications piece, this is where we're either going to be successful or not, because if we don't get this right, vaccine on the shelf does nothing.
Yeah. Thanks, Nani, and certainly the SAGE working group on COVID has had a tough time because the timelines are so immensely tight, and we never worked in this way. We always have had SAGE has worked with vaccines that have already had a license and then made the recommendation. Now it's like we need to foresee on what the data will be looking like, and we have devised a value framework, which is available from the WHO pages since mid-September. And then we have also written up a prioritization roadmap to help countries and the RITACs and NITACs to think on how they should prioritize the vaccinations, knowing what are the present risk groups, who is suffering the most from the disease, or the fact that somebody around them has got the disease or need to be home when schools are locked down. So that has been a very important piece of work where we have, in a vaccine agnostic way, tried to devise a tool and roadmap on how countries should think of their prioritization. But then, comes the tough part, and Ron said it. I mean, he wants the efficacy data, and he wants the safety data, and he wants the serological correlates, and we just simply don't have those. So what are we going to be doing with the evidence to recommendation tables, which, I mean, we have a very nice frame, but then it will be very scanty on the evidence when the first vaccines will be licensed. And that is a tough call. And what do we do if we only have vaccine efficacy data on adults from the US, for example, on 18 to 55 years of age, and if we don't have sufficient data on serious disease in those that we have now prioritized, like the old age groups and the healthcare workers, who some of them are pregnant and some of them have comorbidities, what do we do with our recommendations? So we're trying to work on that. We're trying to be as transparent as we can once we have that data, and we hope to have a situation where the data is simultaneously given to the national regulatory authorities as well as to the SAGE working group, so that we can be there when the licenses are coming out and when countries will start recommending the vaccines. Actually, countries are in very difficult situation right now because many of them have already made contracts with manufacturers that they will buy so and so many doses of vaccine. The same goes for COVAX. WHO COVAX is also making agreements on what vaccines they will buy in a vaccine agnostic way and hoping for the best. So it is a tough call, but if I can put on my Finnish hat on and say that what I see from my own country perspective, this whole COVID epidemic has been a major epidemiology, infectious disease, societal learning experience. The Helsinki newspapers are daily full of epidemiological terms. The entire society is learning on what our nodes are and how they function, what the mitigation measures can do or cannot do. So I think at least in our environment, with a rather high educational level of the population, they are far more receptive and understanding of what's going on, and they can understand risk analysis. And what I'm trying to do in my own communications with the media, I'm talking as honestly as I can, and I talk as if I talk to my patients in the travel health clinic on what is their risk when they go traveling, and what is their risk to contract the disease, how much the vaccine costs, what they can expect from that vaccine. So I put that kind of a frame on and thinking when I'm talking to the media, and I'm talking with the terms as simple as I can, but still factual, and hoping that we're kind of jointly building this momentum, the understanding on where we are and what we know and what we don't know, and what the risks are for vaccinating and what the risks are for not vaccinating.
So Hanna, can you also post in the Q&As the URLs to the two WHO documents, the one on the framework and then the other one that's there? That would be, I think, helpful for people.
Yeah, unless Sonali has already done that. She's quicker than me oftentimes.
She's done the other one for the Canvax one. Now, Naveen.
What we will do is actually, if you send the links by email, I saw Sonali already sent via the chat box, then we can post on the ADVAC website together with the recording of the webinar.
Naveen, one of the pieces that I'm really interested in, I think it's very important for all of our people. How do you see this from an India perspective? You have, one of the biggest countries in the world with a very diverse population, and yet you are going to need to be giving vaccine across a wide range for it to be effective. So what do you see the tripwires around communications here?
Yeah, so if you allow me, before going to India, I just want to say that the biggest problem what we are discussing and biggest problem is to convince ourselves. convince the scientific community, all of us who are sitting here, if every vaccine has its own problem. I was very worried about pneumococcal before I heard Ron Dagan talking about it. We have rotavirus and intussusception. We have oral polio vaccine and VAP and CVDPV. So many other things, dengue vaccine, we had this problem. So I think first we have to, at this juncture, we have to convince ourselves that we do agree and we have consensus on what we will accept as safety data. Efficacy data, of course, it will be coming and we will see that. But if we have accepted that 3 months from the last registration of the, the participant, we are okay with that, then we should stick to that and we should speak in one voice. The biggest problem now coming, gradually I'm coming to India, but the biggest problem we faced in polio also was convincing the medical professionals, and even any vaccine comes, we have to, if we can convince them, the public will accept whatever we say, at least in India, the medical community, and that's a trend everywhere, but we are not sure and we really don't know how to convey that. And it's perfectly all right to convey the uncertainty and people will still accept it. So let us first put our house in order and speak in one voice, have consensus, and then we talk to others. Now coming to India, Noni, we are doing quite well. Our exercise of mapping the health workers is complete. They have enumerated, and it was really nice to see how efficiently that was done. And you can see from the survey that we have very high level of vaccine acceptance as of now in India. What problem we face if you do anything in campaign mode, whether it is polio, whether it is measles rubella campaign, that's very, very, very tricky. And at that point of time, if some misinformation, some AEFI, adverse event following immunization come up, some deaths happen, and that is not managed properly, there is definitely, there is a mass exodus and people start walking away. We saw in measles rubella vaccination that, people stopped sending their children to school. So that's the biggest worry. And I think the work is going on, but as Margie said, still a lot of work needs to be done. How do we tackle that? Everything is coming into place about enumeration, vaccination, cold chain, but this is the biggest piece of worry, that if something happens, and how do we tackle that? We have tackled that very well when pentavalent vaccine was launched. First day there were deaths in Kerala, but that was managed well. So that's the biggest worry as far as India is concerned. Over.
So Keith, we are going to have deaths in high-risk groups. We have deaths already on a regular basis in high-risk groups. Old people die, okay? So there will be deaths with these vaccines, guaranteed. We already know that now. How do we get ourselves ready and the community ready, not to jump to say, oh, well, it had to be due to the vaccine, because we know that's going to happen. The anti-vaxxers will be out there, with bells on. So suggestions, keep.
How do you manage that?
And Susan, I want to hear your comment on that one too. How do we prepare people to expect that?
My dog is also very passionate about this, so pardon him. So I think there's two parts to that, Tony, actually. The first part is that when we look at high-risk groups, everyone's worried about the nursing home patients. They already have a very high mortality rate. And so large numbers of nursing home skilled facility patients in the US die within a year of placement. And so I think we also have to think when we use vaccine, we want to save as many lives as possible. We have to realize some of those lives may already be lost. So it's the first part of that. The second part is, yes, doing vaccines in older adults is very different because we always have deaths. And when you have a group that reviews the data, you need to prepare them for the number of deaths that are going to occur in older adults. Because if a death occurs in a child, the study stops. We can't do that in adults and older adults. And I think there will be deaths and there will be confusion. I think it behooves us to really have good randomized controlled trial data with placebo, so that we can say that this many people without vaccine also did die. If we don't have that data, we're in trouble. And that's actually one of the issues in the US, is that once a vaccine works, do we withhold it from everyone else who's participated in the trial, or do we finish the 2-year follow-up? And the ethics of that are incredibly complicated. But if we can continue to have our placebo group, we can actually have the number of what is related to vaccine.
So Susan, a comment, and then we'll be back to you, Jacob.
Yeah, it's actually quite exciting listening to this discussion, because this group is absolutely critical. This communication is all about open, honest, trusted communication, and actually saying really difficult things. And I think as I'm listening to it, the need for global spokespeople who are trusted, who can go out and say the really difficult thing, is going to be critical. And we need to start developing who those characters might be and who they would be in different countries and different communities. And I think probably drawing from this group is probably a good place to start, actually. Because yeah, it's not just about what you say, how you say it, it's also who says it.
The other piece, can I add to that? And then I want to get back to you, Jacob, on another piece related to this, is that one of the things I think that we have, at least in my country, we've not said well enough is the real understanding that to get control of COVID, for myself to be safe, for my family to be safe, my community has to be safe, my province has to be safe, and my country has to be safe. We all are in this together. It's not like I can opt out unless I want to be a hermit and not see anybody, okay? And the piece about getting different and not the usual suspects in the community to stand up. So I think we need the small business leaders to stand up and say, for our economy to start to flourish again, we need to control COVID. We need to do all the things that Ron and others and Rodolfo were talking about, the masks, the hand washing, the others, and the social distancing. And when vaccines come, that's just one more tool, but we all need all of this. And we haven't mobilized the breadth of community that we need, because we don't usually do that. We don't do the business case for immunization in a way that business stands up for it. But I think business would stand up for us now, because they see what horrible economic impact it has had and will continue to have until we solve this. So Susan, how do we do that? How do we get these players that are not usually our partners to stand up with us?
No, absolutely. We need to build a social movement for this.
Yeah.
I think this is, and I think Hannah, you pointed to it, and we're all getting very expert in epidemiology, but I think this is the giant immunization teachable moment. And, you know, this is, if we're going to create a legacy for generations to come about the value of vaccines, this is when we do it. But of course, it's really difficult that we're doing it in a completely bizarre, chaotic, and you know, uniquely challenging way. But I think we need to have more conversations like this with exactly groups like this, and also take that conversation, that knowledge, that expertise out, as you say, to go and find the influencers. Because if we're going to get back on our feet, a vaccine is part of that solution.
Yep. Yep. So Jacob, back to you. And I think what has run through everybody's conversation indirectly is, how are we going to communicate when the data coming from these trials are going to look different, but it's because the denominators are different, and the points, the point effectiveness pieces, efficacy pieces, are not going to be the same because they're not actually comparable. And yet, you know, the general public, they want to know the facts. And the problem is we've got to be able to make them comparable facts. So how can we do this as a scientific community when we're putting this kind of information out? And I'll give you one little small piece. I know in reading the published trials for at least 4 of the vaccines where you've got the phase 1-2 trial stuff out there, every single one of the ones that I've read has fairly significant pain following immunization. And I will tell you, when you're talking to adults and you tell them something's going to be painful, they are not happy campers, okay? So what we need to be talking about is how to manage that. And there are things we can do, but how that gets presented in a way that is, well, I want that vaccine because it looks like it's less painful than this one is. You know, like, how do we really make this more understandable? Jacob?
My short answer is I don't know.
Well, I'm wondering if we could have a cross-platform way of being able to compare the data, because I think CEPI has to be one of the organizations that could do that.
Yeah.
It's very difficult to do it from the published studies. It's almost impossible, but somebody's got to be able to credibly put that out there, because you don't want 16 different groups doing it in a slightly different way. So Keith,
Yeah.
what do you think we can do?
So here comes
Jacob.
a longer answer. If you look at the published protocols, there's 5 out there now, and I have to say that if you look across them, the definitions, the case definitions for COVID-19 endpoints differ.
Yes.
And a lot of other aspects in these trials differ. The consumptions of paracetamol that is used around vaccination completely differs. So that's why I said I don't know, because simply the protocols and how these trials are being conducted already differ, not to speak of different platforms and things like that. So in the end, the point estimates, and that's really what everyone will look at, a point estimate for vaccine efficacy. And just a general statement, it is fairly easy to demonstrate the presence of vaccine efficacy. You know, that's a statistical randomized controlled trial matter. But it's very difficult to demonstrate the absence of safety issues, because that you cannot do based on statistics. You know, if you don't see anything, is that a proof that it doesn't exist? Even in 30,000 trial subjects, half of them exposed to vaccine. This will only come from long-term safety surveillance post-licensure. And someone put in the question and answer string, you know, that in the past we have rushed into deploying vaccines in previous pandemics, and there is a risk related to that, and that's true. But in a pandemic, everything is about speed. If we wouldn't rush, if we wouldn't try to get these vaccines developed and out as quickly as possible, we have no choice. But, and here's maybe my answer to you, while of course everything has to be related, the point estimate of vaccine efficacy has to be related to other characteristics. And Keith made an important point in that, can we continue with placebo-controlled trials once first data have been released or first emergency use approvals have been granted in some countries? Would we still be able to continue placebo-controlled trials with the same vaccine, or controlled trials with when other vaccines have been deployed? We had a workshop on this last week, and there's another workshop organized by WHO tomorrow on just that question. And we may run into a situation where we receive first point estimates around vaccine efficacy in the very near future and safety data. And then we will see emergency use authorizations soon after that, and we may have to switch over, and there might be a lot of pressure from trial participants in blinded trials to receive vaccination. And we may no longer be able to start new placebo-controlled trials in some countries in the near future. So an alternative would be non-inferiority trials, for example, but then these are very large, and we already discussed this with regulators. One cannot just focus on point estimates. So let's say we have a point estimate vaccine efficacy of 70% for one candidate. what is your margin? Would you still allow a vaccine that is within a stringent margin? No, we have to take into account additional characteristics. If you have a 70% point estimate for vaccine A, and maybe a 55 point estimate for vaccine B, but vaccine B has a single dose regimen, can be stored at 2 to 8 degrees, is immunogenic or safe in risk populations, that is something that the regulators will have to take into account. And then one final comment, in the end, and that's also from, we discussed communication, and that's what it makes so important. I think as soon as there is events and we cannot really control communication in the public and in the media in the end. I mean, we can be prepared and we can try our best, but we cannot control this, simply because all here in this call, I guess, understand the risk-benefit concept, but the lay public do not understand this, and it's impossible to transport this idea over to the lay, to the vaccinees, to the general public. The expectation is you have a completely effective vaccine with no safety issues, and that's never the case. So all we do, in particular in the pandemic, and that also applies to the comment I saw in the Q&A session, to rush into vaccine deployment, in the end, it is simply a risk-benefit assessment. Right now, we are in the middle of a pandemic and people die. And yes, we would like to have 10 years to develop a vaccine, as we are used to, but we simply can't. And that is something we need to prepare for. The risk-benefit, which we all understand, the regulators understand, the public health experts understand, is out there, but it is impossible to really explain this. And that's also why I think the COVAX structure is so important, because it really brings around the table not just the developers and the regulators and then some public health authorities, but we really have WHO there. We are partnering with Gavi, CEPI is there, a lot of organizations, really everyone on this world that is really involved in some sort of vaccine development, deployment, manufacturing, licensure, guidance, policy, is partner or contributing to the ACT Accelerator, and in particular to the vaccine pillar called COVAX. Over.
So basically, I think what we're hearing loud and clear is there's a huge importance of developing, if we can, trust in the whole process, because we don't have a cut end like we usually have. We're not there yet. We're going to know how to use these vaccines 10 years from now really well, okay? But we can't wait 10 years because literally millions of people will die in the interim. But it's trust in the process, trust in the system, trust in the program. And it's also about transparency. It's trying to, as Jacob said, make people able to understand why these are not one and the same when we've got these point estimates, where you can't compare in the way that, Ron's wearing a lovely plaid shirt and Rodolfo's got a blue sweater on, but they're not the same, but we need to be able to compare, well, how warm does that keep you, or how cool does that keep you? Like, we've got to be able to use language that the general public can understand when we are comparing and contrasting. And I think that's not easy at all. So keep back to you for comments for how do we reach seniors? Because, we're so used to going after parents or pregnant women, all right? And not the population that that we're going to be doing.
Margie had a comment real fast. Yeah. I'll let her, and then
Margie.
Thanks, Kip. Noni, I just wanted to add, I think one of the problems or one of the mistakes that we make all the time in vaccine communication is that we oversell vaccine safety. I think it's going to be critical. I mean, we're all talking a lot about the data that we don't have and how challenging it's going to be. First of all, I think the public actually just want to hear what we do know, and that it's actually okay to say what we don't know. And it's that transparency that builds the trust. I think we need to be careful we don't put too much store on the data and that we don't have the data, so we can't do this. We need to be focusing more on the generation and building of trust. And certainly in my conversation with vaccine hesitant parents, if you oversell vaccine safety, you lose them at the door. We know these vaccines are going to be reactogenic. We need to be preparing the public, telling them they're going to have a sore arm, they're going to have a fever, they're going to feel achy and have a headache for a couple of days, so that people don't feel that the vaccine's unsafe and rushed. that they know that's going to happen. So I really think it's that preparing, and it's the way we communicate. I think we need to move back a little bit from the data, intensely on the data, because I don't know that that necessarily builds the trust that we want. And the only other quick comment I was going to make was about conspiracy theories. Of course, all this communication is happening in a zone where, like we saw with in Russia with the Sputnik 5 vaccine, you know, and all the issues around that. And then they came out and said that the Chadox vaccine was going to turn everybody into monkeys, you know, and we saw all those images coming out of people in suits walking around as monkeys. You know, Susan said it, we need really strong, clear advocates that come out quickly and counter that sort of stuff so that those conspiracy theories don't take hold, I think.
Yeah, I'm going to jump in and then please follow. One of the pieces that I think you've subtext said, but I think has to be said overtly, we have to become part of a we. It's not a them versus us. It's about all of us in this together. Here's what I'm bringing to the table, my understanding. Here's what you're bringing to the table. Here's what Susan's bringing to the table. Here's what the business community is bringing to the table. Because we need all of that we together to be able to make this work. And there's actual evidence for this. I know in our pain mitigation stuff that we've been doing a lot in Canada that, you know, when in the school-based programs to make them much more positive experience for the students, when the nurse becomes part of a partner with the student as opposed to just being the immunizer, they become a we. How are we going to make this the best experience it could be? It changes everything. So we have to figure out how to get that we partnership piece. That's a real partnership. It's not fake. It's the real meal deal. So Kip, going back to, you know, I have to tell you, a lot of 80-year-olds I don't think are on Instagram, and they're not on Twitter. Now, some of the 70-year-olds are on Twitter. They're on Facebook. They're on Facebook. But what I'm saying is, I think, you know, we're so used to thinking about our communications programs in a way through lenses with tools that fit the age groups that we're used to dealing with, and have not gone back to say, so like, I'll be quite blunt here. I think in my own country here in Canada, we need to actually be working with religious leaders across the country, because you're much more likely to be at a synagogue or a mosque or a church or another religious group when you're in the over 60 category than if you're under 60 category. And they need to be part of our partnership that we would build. I don't know. I mean, this isn't, we don't have the huge breadth of background that we have for, and the data that you were talking about, Marky. We don't have that behavioral, social, where do you get your information? We don't have it for the same breadth as we do.
It is totally lacking.
Yeah. And why aren't we doing something about it?
We have been totally focused on trying to make a vaccine that actually creates an immune response and is effective in older adults, and actually prevents disability and life loss. But we have not focused on behavioral aspects and the questions. I think that's going to be key, and it's going to be very different in every country. You know, there are going to be countries that are like, no, you do my children first. You do my grandchildren first. And then there's going to be parts of the US that are like, I'm getting it first because I'm most likely to die. So I think there needs to be a huge amount of research done in this area. Not only what their knowledge is, what their wishes are, and how to communicate with them.
I want to expand that a little bit. Sonali and I have been collecting questions for the CanVax Q&As on safety. And one of the ones that has come in since, that will be on to the next one, and it was a fascinating question to me. How do you explain causality? So the question really is, frontline worker, how do you know if something caused the safety problem? All right. Dad, actually, we do lectures and lectures about how you assess causality. So Sonali and others on the working group are trying to figure out, how do you say this in 250 words that is understandable, or 500 words, you know, that little bite that they need to understand? And how do you explain it not? So I don't know, Sonali, if you want to comment on some of the other questions like that, where And it's very basic. Like, it's not simple.
No need.
You're muted, Phil. Can you just unmute?
Sorry, before turning to Sonali, may I actually bring a few comments from the participants, because I think they are relevant to the discussion. And I want to zoom first to 3 points raised that are not so much question, but comments. And the first one was made actually by Pierre Van Damme, where he says you will see a lot of parallel between those who don't want to follow the COVID-19 measures and those who are hesitant vis-a-vis COVID vaccines. And this will need to be taken into consideration. And there were 2 more recent Lias made comments from Yoti, that we need to trust the community to understand and keep the message simple. And it reemphasizes some of the points made, and have trusted messengers, trusted messages. The community is us, so they will understand. Why think otherwise? And we need to make it clear that the vaccines is not the complete answers. It's important, but not the only solution.
Exactly.
Some of the participants are concurring with the issue of the need of trust, the need to bring things to the community, and that the people are part of the solution, but also the need to look at the armamentarium in a wider manner, and to accept that vaccines are not the only solution, and keep that also in the communication. I'll pause there. Sorry for bringing this.
No, that's helpful, Philippe, because it's basically reinforcing some of the pieces that we've been trying to emphasize here. So, Sonali.
And just to add to that, Philippe, so it's, based on the work that we've done in the past, we also need to work closely with stakeholders, including politicians, media, public and private sector health providers, community and religious leaders, high-profile health experts, educators, and civil society organizations. And we've really found that this is really useful and helps get the message across, because these people engage with communities that we do not, we might not have access to. And of course, we need to engage with communities, but adapt to different population groups, and perhaps set up a national panel of experts, set up a politically neutral bodies, considering the high amount of distrust that we're seeing in some population groups. So having these politically neutral bodies set up, the national panel of experts, might be another way to go. And just going back to Noni's comment, what we found that, so to extend something like a risk-benefit analysis, we tried doing that in the answers. And we found that it was really useful to use graphics and diagrams to try and get the information out, or use practical examples that people might be able to understand.
Rodolfo.
I would like to comment that this problem, of course, is going to vary. It's different depending on some regions. In Latin America, we are a region that is kind of pro-vaccine region. Our uptake rate is really high, among 85 to 90% in uptake rates in the infants for the infant vaccine. And most of the problems with the uptake are more linked to the affordability for the countries to introduce some vaccines, or the sanitary system, more than the hesitancy. The hesitancy is maybe around 5%. So, and most of the countries in Latin America, maybe all of them, they have mandatory policies for vaccination. So maybe, of course, it's not going to be the same at the time of the COVID vaccine deployment, because the fear is going to be part of and uncertainty is going to be part of the problem, and it was going to be a main issue to discuss with the communities. So the messengers that of course, we need a good messenger, but nowadays maybe it's going to be helpful to engage the healthcare workers, the frontline healthcare workers, because they turn, the community turned to them to see them as heroes during this time.
Mm-hmm.
So the people start to, they refer lovely with the people who was in the front line. So maybe to show them as an adopter, as the early adopters of one of the vaccines, is going to be helpful to build a trust in the community. It's like to support them. So we need to work to engage the healthcare workers, because I guess that maybe it's going to be seen as a close messenger, a closer messenger for the communities and for the population. Over.
Ron, you raised the issue that you're in your 70s. All right. So you might be in a group that might be near the top of the list, and you're also a healthcare provider for getting the immunization. What is it that you think you and your colleagues would want to know? Not what we know now, but would want to know? Because I think, as Rodolfo's saying, we need healthcare workers to be trusting in the system and in the vaccine.
I think I would, if you permit, I would change a little bit the question, because what I want to know everything. Okay, everybody wants to know everything. What I read the literature, but also in terms of communication, I don't reach a 1/1000th of what a 24-year-old TV news reporter reaches. And she reaches New England Journal of Medicine last paper before I reach, because I have to see patients, and she gets it on her table the moment it's out on the online. And I hear the first news from that 24 lady or man who explains to all of us what was found, and she finds a sentence like, I want to tell you that about 1 out of 1,000 of the recipients had convulsion. Okay, so here comes the communication. Forget about me then becoming apologetic. So I think what I want to know is that, and this is also a proposal, that there is an international committee with a roof of the WHO that makes something that the TV reporter will cite, which is a document of what's new and how to take it as compared to the current information, the type of the boxes we have in what's new, what we know, what's new. And if this is daily distributed during the deployment or weekly distributed by this committee of people, the Noni McDonald's people, okay, that actually people trust, okay, Fauci's, not new, whatever. People trust as a combination of people that stand up to either the president or whatever and tell them in the face the truth. And they say, this new paper that came this week shows us X, Y, and that, puts new questions, because every answer puts new questions. But before we had this paper on the 79 years old American who you can protect 50%. Now we have this paper that tells you that 50% is not 100%, but in 5 years, what 50% can bring you to the herd protection, it's a very reassuring finding. And this adds to what we know now. So it comes to your initial question, how to get with the confusion. I know, and you know, that when you open the morning the TV, they will have this document from WHO, and all of them cite, WHO states that, the International Committee on New Information from WHO brings that to our attention, A, B, C. And that is feasible, that is practical. That is not like wishful thinking, but it needs somebody to be the champion to collect, to assemble this committee of 20 people or 22 people that are committed to sit every week or whatever, to make Zooms, to prepare something that will be going out on the name of this committee, and that people will start to be used to wait for this, because it will come. And so if we create that, we create something that people are now going to be hooked to be, if you will, almost addicted to. What is the next message from this committee? like Fauci's. What is today's Fauci's message to us? And I think this is the only thing that I look at it as me, you ask what I want, I can then use it to talk to my patients, to talk to everybody. This is the consensus that comes from the biggest international, forget about the interpretation of X, Y, or Z, or Wakefield, or whatever. These are the biggest one. Altogether, this is the biggest brain we can have. That is my wishful thinking.
You know, Ron, there's actual evidence that that type of a strategy works. There are some countries, I want to be very small p political, not big p political, so I won't name the country, but I was in a country that has an extraordinary vaccine uptake rate. They can't imagine why anybody's hesitant, okay? We're talking in the high 90s, okay? And they had an adverse event, and they were on the TV that night and said, this adverse event happened in such and such a town. This is what we know so far. We'll be back to you tomorrow night with more information. Next night, they're back with more information. And the trust in that, because it's an august body who's being transparent and being open and sharing all the way along, it was extraordinary to watch this happen in real time. You just wouldn't see it. And one of the issues you brought back is, I don't know about your country in Israel, but I'll tell you in Canada, the problem when anybody stands up to say anything, it has to have been through like 50 bureaucrats and signed off before anybody will let it out the door. And Hannah and I will tell you that's true at WHO, you know, like it's really hard to get something out quickly. I don't know about Gavi, Susan, but it just takes so much checkoffs that the speed is.
I know Keith is on the thing here because he sent a remark. So that can be done through the Gates Foundation or something. It doesn't have to be the WHO, but it has to be something that has the trust of being not political and contain what the media believe are the smart people, not what we think. Sometimes it's the same, but not every time. Okay, so it's people that the media accept and as a group and international. I think that exactly this, we come back to you and now, I mean, I guess in 6 months, 10 months, 12 months, everybody will be struggling with new vaccines. What we do with them? We don't have them, we do have them. We got this vaccine, but we wanted that vaccine. How we keep them, how we give them. Something needs to be put some water on the fire, and that is a part of the water that I see, preparing it now to be used in a year from now.
Yeah. Hannah?
Basically, I mean, the stage is out there to do these deliberations and have recommendations, vaccine specific, not brand specific, but I mean, vaccine specific. But it is a very slow avenue. You're right in there. Right now, we're looking into whether the right tags could, how much they could help, and what the night tags could do, and how much they could help. I mean, we know that in many Western countries, they don't necessarily listen to what WHO and SAGE does, but they listen to their own night tags. But that may be changing in this situation where it really is so that everybody's in the same situation where data comes in bits and pieces, and there are so many vaccines that also come out in bits and pieces, and we simply don't know. So I mean, I don't know, Ron, what you think of would be the best place for that. I personally would like to promote the UN institutions and to bring stability to this world and also stability in health. But it's been a tough call to be a kind of a Speedy Finn who wants to get these things out, and it takes a long time to get statements out from the WHO. I suffered from it personally. I mean, very frustrating, but
that's why Sonali and Hannah and I that are on this little working group putting out these Q&As, we did not go through any of the major organizations because we knew that when did the Sonali, the group got together the middle of September, and it's posted today. Okay, and there will be new questions out probably in another 2 weeks. Like, we just couldn't do that turnaround in most organizations because it needs too much box ticking, you know. And the same for the translations that are going to be done.
What would be the place?
Yeah.
Where would be such a board of wise women and men that could
Could
take care of
Gavi
this.
do it, Susan?
And it's interesting because I have had, we have been approached with a sort of an idea for this. And I think, of course, you know, the issue is there isn't, I mean, we can look at global bodies, but also a lot of this is quite community specific, or at least country specific as to
Or context specific.
Context specific. So I think clearly we're going to need a kind of network approach to this. But you know, I think cascading from how can you get trusted influencers into a space where they could be a kind of independent, neutral body that would then be looked to. And I think certainly from this call, I will pick up that idea that we've been approached with and have a look at, you know, and I think it's this all of society approach that we need, that everybody is represented and that all, you know, all interests are there. But I think it's, and we also need a kind of something a bit like the elders, don't we? Or do we need the elders themselves? But that's, you know, that's the kind of brand and trust that we need, that you know, somebody needs to speak for this very bruised and wounded world right now.
The one thing that you have in industry, when an industry becomes too big and therefore start to have a problem, they create a daughter company. And that daughter company is smaller and faster and can do things. And it's not a joke. I think WHO or whatever has done that before. Gavi actually, I think, was one of the daughter companies in the past. And you can actually create a daughter company that will be company for communications of COVID issues. And that will be created specifically for that, with another mechanism where interpretation of new data are the goal. We have now almost a year before really everybody will get the vaccines around and whatever. That is enough time to create an organization that is made with the roof of whatever, that will be done exactly for that, and therefore there will be some shortcuts that will be allowed. That, again, I may be very naive.
Noni, I feel, knowing particularly where I'm coming from, a few years ago, I feel a bit sad to hear some of this discussion and some of the perceived challenges to have WHO play its role in communication. So I hope that part of the solution is not only to think about subsidiaries or creating more infrastructure, but for the sake of efficiency to make sure that this type of discussion, this type of concerns are really heard by WHO, and that it can actually improve this interaction and facilitate the issuance of the messages. I know in the past it was possible, and I don't see why it would not be possible these days, despite the fact that WHO has really been in front of the gun for a number of reasons over the last months. And some were really, I hate to say, but I think were bad reasons. So I would encourage all of you to bring through your own channels some of the concerns and try to have this positive impact. And it's unfortunate that indeed today we have nobody directly connected with WHO on this panel by virtue of circumstances. I don't know if they are participants from WHO, but all of you are working closely, that it be you, Susan, Hannah, Jacob. Many of you are basically in daily contact. So I think that coming from a cohesive discussion, that would be important.
So we don't have that much time left, but I wanted to shift gears to one of the other areas where I think communications is going to be critical. And again, it's different with the COVID vaccines to what we've done before. These vaccines, as Ron aptly said earlier, they may need different storage requirements, the number of doses that are going to be needed, the actual dose amount may be different. And what vaccine that individual patient got will be critical, because if there is a serious adverse event, you need to know what vaccine they got, not just they got a COVID vaccine, okay? And never before have we required the individual to know that precise information in the same way that we're going to need to know it now, okay? So I'll be sarcastic for a minute, but suppose Keith gets immunized, and she ends up having a heart attack. Okay. And then they're going to say, okay, what kind of vaccine did you get? Did that cause your heart attack? That somebody's going to say it did. All right. And you're going to say, well, I got the COVID vaccine, but I don't know which one. And so all of them get tainted with the same brush. So the two pieces I want to talk about here is it's about the communication with the frontline worker, ensuring that they're given adequate training and background information so that they are confident in being able to deliver whatever vaccine they're going to do in the most competent way, so we can decrease the program errors. And then I'm going to jump back on manufacturers for a minute on that. And then number two, we need to have communication structures in place so that not only does the healthcare worker mark in the chart what the patient got, but somehow the patient actually gets to know what it is they got, not just the COVID vaccine, but what one. So, and let me do the one other piece. The manufacturers, I think, can help here by how they put their diluent and their product together so that we're going to have less probability of errors. And Lee Hampton's written a nice paper that's in Vaccine on that. And this isn't something we can figure out 5 years from now. We need to have figured it out soon because we want to decrease program errors. So I do think manufacturers have a role in making this as simple as we can make it. So Keith, you're going to add a point.
Yeah, actually 2 points. So that's actually one of the things that we have not fussed at, strongly encouraged, discussed with at length with our American colleagues about not only safety, but effectiveness, I should say, because we're going to do these studies in very controlled ways, and then we're going to introduce these vaccines into frail elderly and people with immunocompromising conditions and comorbid conditions. And if we're really going to know these vaccines work, we have to know which vaccine the patient got. And I am less worried about the patient knowing that there's some centralized place with this information. If we have to go patient to patient to figure this out, it's never going to happen. So there needs to be a very structured way. What's the barcodes? Everything's going to have to be barcoded. We have to figure out a way to make that happen. And it's not just one vaccine. What if they got dose 1 of one vaccine and then they went someplace else and got dose 2 of a different vaccine? And did it work that way? And were there more side effects or less side effects? All that are questions that we're going to be dying to answer as soon as these vaccines get introduced.
That's exactly the point. Is I really think it, I mean, this comes from having been on the data quality stage working group. We really need to be thinking about data in a quite different way here, and we need to be able to get it. So in the parallel, if we had fully integrated patient-centered health information systems, fully integrated means every way you could come into the healthcare system, this isn't a problem. But there are very few countries in the world who have those kinds of systems. And without them, we end up shooting ourselves in the foot over and over and over again and chasing our tail, trying to find the information. And we need to be thinking about how to do the best with what we've got, but improve it when we know this is going to be a tripwire for us. So, Phil, you had some comments that are out there that you'd like to raise as we've got about 10 minutes left.
Thank you, Noni. Yes, indeed. I thought I should go through some of the remaining questions and comments from the participants. And I will go in no particular order, acknowledging also that some of the points are essentially hammering some of what has been already discussed. I'll start with a comment from Joseph Weigel saying that the risk by age for the wild type infection is known versus the unknown risk by vaccine. So there's clearly, when you look at different age groups, this present an issue. And that type of consideration also should go way beyond the vaccines. We also have another comments by Yoti that pharmacovigilance and public health versions of causality need to be aligned better, that there has been a gap area and this is an opportunity to bridge it. And that the phase 4 of a vaccine, which is an often repeated but less studied area, and that this should change for COVID vaccine. So he's also asking if there are specific plans for phase 4 monitoring for these varied COVID vaccines. I think that maybe it's a far-reaching question. I'll list a few more, Noni, and then perhaps pause so that there could be reaction, and then I could come up with the last batch. Chinara Ediralieva also points that during the 2009 pandemic, there was the wasting of billions of dollars and millions of doses of vaccine. Everybody wanted the vaccine, and then when the vaccine started to be deployed, nobody wanted it. And that special attention should be given to the communication and behavior change, also for the 2-dose schedule. Otherwise, there would be dropouts and defaulters would affect the efficacy of the whole COVID-19 immunization, so that risk communication, preparation of spokesperson, and press release for the safety event should be well established in advance. There were, maybe I'll line up one more comment from Rick Bright saying that in addition to identifying trusted messengers in each country and region, should there be a repository of consistent trusted messages for the messengers to align with suitable nuances to reduce confusion and conflict, which I think echoes some of the, very much some of the previous discussion. Perhaps I'll pause there, Noni, and have 5 or 6 questions again or comments that I could line up.
So Hannah, I'm going to put you on the hot seat with Jacob here. I think phase 4 trials are going to be critical, okay? And how many of those are likely going to happen, and they need to be done really quite systematically, not just, well, we'll collect whatever serious AEFI happens and we may miss some stuff, but who cares? Because this is, what is it, 7.7 billion people in the world, and if we want 60 to 70% of them immunized, that's in the billions. So when you've got a denominator of billions, you are going to have many, many serious AEFIs. It's going to happen. And we need phase 4 to be able to have those looked at really well when we've got millions as denominators. So Hannah, will SAGE be recommending how those should be done, or is, how's that going to happen?
There actually are already working groups in the WHO regions and looking into on what are the vaccine effectiveness protocols, what elements need to go in there, and what are the safety protection. The regulatory authorities most likely will request the market authorization holder that they have a conditional licensor, meaning that phase 4 studies need to be carried out by the market authorization holder. Where and how they'll do that, and what kind of a criteria the NRAs will put on that, I am not privy to that information, but certainly that will be part of the package, the licensor package. Countries that have established vaccine registers can of course do vaccine register studies, but then there will be more active surveillance studies and basic surveillance studies using epidemiological methods such as test negative designs, or self-controlled case series or case series. So all of this is being looked into right now, and countries are preparing themselves. The program offices that are in charge of the rolling out, they're in liaison with their NITACs and with the RITACs, so that we are getting there. But as you know, it will take time.
Yes. One of the other pieces that goes with that, Hannah, is one will expect those to happen fairly expeditiously in high-income countries where the regulators will ensure that it happens, but it's the middle and low-income countries where we're going to need the same kind of information being collected, because the population isn't the same and the risk factors aren't the same. So we need to have a way to ensure that that's going to happen, even if it's in WHO pre-qualified vaccines are going to those countries.
Yeah, and I think it's a matter that COVAX needs to think about on when there is a donation of a vaccine to a low middle income country, then what are the prerequisites? And one of the prerequisites is to have sufficiently reliable safety and impact studies in place. And I don't know if the CEPI person on this call could comment on whether this is something that is already being thought about, and who is in charge of those study designs and protocols?
Jacob?
Yeah, so first of all, the majority of vaccine candidates are being tested in fairly large phase 3 trials, so ranging from 30 to 60,000 subjects, so half of them exposed. So we will have a fairly large safety database to begin with. However, we expect emergency use authorizations or licensures in the very near future. So the long-term follow-up is going to be limited for the time being. So I couldn't agree more with the statements that pre-licensure activities have to be aligned with post-licensure. And a lot of, particularly on the safety follow-up, will have to come from post-licensure observations and activities. Now, this is where, again, things get complicated. We have a lot of discussions within COVAX. I'm leading the clinical development SWAT team within the work stream, the research and development work stream. So we focus on pre-licensure activities, safety aspects. It is required, at least in, for example, Europe, but also by the WHO PQ group, to submit a risk management plan with to obtain a pre-qualification. Some developers have not gone through licensure yet. Some have not appreciated the concept of risk management plans and pharmacovigilance strategies and post-licensure activities. And then the ecosystem is complicated. So we are in discussion with WHO, the GARCS group, the WHO vaccine safety group. CEPI has set up a project together with the Brighton collaboration, which we call SPEAK, and they have set up a meta DSMB to observe signals out of different programs. So are there signals that we need to monitor across programs? So there is a lot of activities ongoing, but it is quite a complicated field and environment. What is the responsibility of the developers themselves? Who is going to pay for those post-licensure, post-approval safety studies? And just to make a general comment, I mean, this is a new pathogen. We only know this for 10, 11 months. Yeah. It is a pandemic and we are all completely nervous. There is no vaccine out there for coronaviruses so far. We have some evidence from MERS and SARS-1, but maybe that even complicates this further, as vaccine-mediated enhanced disease has been addressed from these previous studies. And I'm completely saying that no evidence that this exists with SARS-2 as well, but we have to look out for that. So we do need long-term data. There is no correlative protection. So the question, I think there was also a question in the Q&A section, is this really the time for new platform technologies? And I would like to respond that, well, think of the 2009 pandemic and the influenza vaccine, the multi-dose containers and the preservatives, the thiamerosal discussion, the discussion around adjuvants. That's all, you know, influenza and long-term. We have lots of tons of data on influenza vaccine, and still there was a lot of hesitancy related to preservatives. We cannot cope and fight this pandemic with pre-filled single syringes. We need multi-dose containers, we need preservatives, we need adjuvants for these conventional vaccine platforms. So there is a chance, not just in terms of speed with developing and manufacturing vaccines based on new platform technologies, but also a chance to have safe vaccines out there. But I have to say it is key, and I can only encourage really everyone to sit around the table and take this vaccine safety pre-post licensure up in a constructive joint manner to see that we can generate this evidence as quickly as possible, and in a concise and complete manner, covering all these. We have to cover post licensure in different countries, but also for a series of vaccine platform technologies. There will not be the one COVID vaccine. Over.
So given the very short little bit of time, I'm going to ask you, Susan, for your last comments.
I think this has been an extremely valuable discussion. I'm certainly taking quite a lot of ideas that I hadn't thought about away with me, but I just want to end on, Margie, your point. We can't do any of this without really good behavioral data.
Phil, can we come back to you for your wrap up?
Okay, so apologies to the questions that will remain unanswered, or the comments unasked. I mean, many of you have been able to to see these comments for yourself, but there's so much we can do with time. So just to close, I want to inform you that the scientific committee of FADVAC has decided that it would be a good idea, probably early December, to organize another ADVAC webinar yet on COVID. And you may be pleased to hear, because I think it matches nicely some of the comments made during this discussion, including in particular the comments from Ron, that would be on the meaning, helping people interpret the meaning of the results of clinical trials. So once we have just the results coming out, and they'll come out one by one, what does it mean in the grand scheme of things? So I think it would make it for a very timely and very interesting webinar again. It remains for me to thank Susan very much for a wonderful presentation and fighting the disease to do that. So it's surely, I feel so bad to have imposed that on you, and you did a wonderful presentation. Thanks to all our panelists. I mean, this was really an excellent discussion, and thanks so much for this contribution. That's the advantage, I think, of the ADVAC webinar. It's a multifaceted discussion, bringing everybody to the table with a freedom of speech. And often it goes with interesting ideas, and we hope that the ideas won't die after just the meeting or the webinar. I want to thank all of the participants, all of you, for the questions and having joined for this webinar. I want to thank Carol Carol Berrysville, who is always doing a lot of work to help organize these webinars and remains in the shadow. And Noni, thanks indeed for accepting to chair and doing a masterful job in sharing this webinar. So thanks again, everybody. And I guess we'll see each other for the next one. So thank you, and
thanks, Bill. Everybody stay safe.
Okay, bye-bye.
Stay safe. Thanks, Noni.
Thank you very much.
Bye.